Hi, it's Joy again. So we stopped at the water breaking and coming into labor kinds of stuff, and then sort of like why we would maybe want to avoid infection for the baby. So now let's talk about interventions. So some people come in and they're exhausted and they're 2 centimeters dilated and they've been laboring on and off for the last couple of days. They haven't slept well through the night, and they need some help. But they say to me, I want a natural labor. I don't want any interventions. Okay. One of the suggestions I might give is for therapeutic rest. Yes, it is a narcotic and Benadryl injected usually in a muscle for long-acting relief. But its goal is not to give you a medicated labor. Its goal is actually to get you to rest so that your body can labor, so that you don't need to have all this other stuff that we do intervention-wise. Exhaustion is one of the number one reasons why women opt for epidurals. Epidurals are not evil. They have many good uses. So therapeutic rest is used to try to get women that rest they need so their bodies can labor. A couple things can happen with that. Tuck you in, let you go to sleep, and you wake up and the contractions are gone. And then I have an angry mom who wanted to be in labor. But really what we did was we addressed the issue. She was exhausted. Her uterus was grumpy. Sometimes we've given you IV fluids, we've given you hydration, and that has calmed those contractions down. In a preterm mom, that's actually very beneficial. We don't want a preterm baby. But in a mom who's 40 weeks who wants to be in labor, then she's grouchy about things. But we've revealed the truth of it. Is this real labor or is it not, right? But other things can happen. So sometimes I give you IV fluids to address dehydration, or the therapeutic rest shot, and 3 hours later, you're in rip-roaring hard labor. I've addressed the issue. I've given you some pain relief, I've given you some rest and some IV fluids, and look, now we have good labor that can then progress on its own, and you have much better coping ability. Therapeutic rest will not hide true labor from you. Most women, when they are in active labor, say, this is doing nothing for me. This is not giving me pain relief. That's okay. That's not what its intent is. Its intent was to give you rest in the early stages of labor before active labor. Sometimes we use therapeutic rest, say you have to come in for an induction for some reason, and we're starting to use that cervical ripening kind of softening medications instead of, we're not starting off with Pitocin. That therapeutic rest will get you through those early stages. Induction of labor is exhausting. It is a long process. We are a hospital. We have to monitor you. We have to check your blood pressures. We have to do all this stuff. It is hard to rest during all of that. And so the goal of that is to get you through that early stages of cervical ripening before we actually start the contraction phase, and you're not exhausted so that you can cope. And we have had women who've come in for inductions who don't get epidurals, but they have used things like therapeutic rest to sort of help them be able to cope through some of that stuff. Other interventions, so women come in, they say, I want my epidural. There's no rules on epidurals. Epidural, generally, we're not going to give you one until we're sure that you're in labor, or say we're doing an induction that's a little bit different. We might move to an epidural sooner than we would in a normal labor. But once we know you're in labor, and yes, your cervix is actively changing, epidural, we don't have rules to that as to when you can get that epidural. We do try to encourage you to move and try other forms of pain control first, mostly because once you have an epidural, we have very limited positioning to use with you, and so it's hard to encourage that baby to kind of wiggle and move down through the pelvis. So keeping you in bed is difficult. You also then will need to drain your bladder either often with a straight cath or put in a tube to keep emptying your bladder, because epidurals prevent you from being able to pee. And that's okay. I want to keep your bladder empty. I want to keep space for that baby to come down in your pelvis. But people often talk about that cascade of interventions. Once you have one, then you have another, then you have another, and that's sort of an example of that. Once there's an epidural, then we need to drain your bladder. Then we have to position you and can't move you well. Epidurals are powerful. They numb you, supposedly. They're not perfect. We don't promise a pain-free delivery. But they numb you from here down. Very limited movement of the legs. You're not to get out of bed because you won't be able to support. Even if you can move your legs, you're not going to be able to support your body. So you're not going to be able to get out of bed. You can't urinate normally. And the goal is to control the contraction pain. A lot of women still feel a lot of pressure when they deliver as the baby comes out. And some register as nothing, and some register as extreme discomfort with that. There's very little to control or how to prevent any of that. But in general, epidurals do very well at controlling that contraction pain, and that's the point of it. Uses involve pain control, allowing a mom to relax, complete exhaustion from labor, so mom needs to rest, so that's it. The medicines can be used in some instances where a mom might have high blood pressure, and those medicines will help keep her pressures low. So epidural medication will drop a mom's blood pressure. To avoid that drop in blood pressure, and then the consequence of that is a drop in blood flow to the baby, we usually need to do about 1 liter of IV fluid through the IV first to prevent a drop in her blood pressure that would then affect baby's heartbeat. If you get an epidural and your blood pressure drops and the baby's heartbeat drops, we give you IV fluids, we give you oxygen, we lay you back, roll you on your side, and we can usually fix that problem, that we know why that's happening. And usually then we proceed on and have a normal labor and delivery. Other reasons for epidurals. Just because mom wants them.
Mm-hmm.
But they're powerful and they're very useful, and sometimes in a long labor they're recommended so that we can see if we can proceed towards getting this baby out. IV fluids are an intervention. Treatment for blood pressure issues. A baby heartbeat dropping sometimes is just related to blood flow, and so IV fluids can help with that. So if for some reason labor isn't progressing, your cervix isn't dilating, then we need to think about why that is. And so sometimes all I need to do is open that bag of water. It releases the amniotic fluid. The baby's head can come down on that cervix. And that is what causes normal contractions then to proceed, dilation of the cervix and the baby to come out. And so sometimes I use it just as a form of allowing the baby's head to come down on the cervix if the baby's sort of floating in that amniotic fluid. Sometimes, even with that, labor doesn't progress, and we need to try things to see how can we get this baby to come out vaginally. If labor is not progressing, usually we will want to start some sort of contractions somehow. So if you come in and your water's broke and you're not dilated and it's your first baby, we're gonna need to get that cervix soft and right first. And a couple different medications, misoprostol, Cervidil are both prostaglandins that cause, hopefully, cervical spasming and softening, and can sometimes cause contractions. Cytotec is used every 4 hours. We use it here mostly sublingual or dissolved in the cheek, and the power is in the dissolving. That is going to help give you the kind of contractions you want. If you swallow it, it gives you lots of cramping, but in diarrhea form, so it's not really what we want. We want just this to dissolve. And then every 4 hours we can reassess, do you need more? The risks of it are that it will cause sometimes contractions, and then we need to monitor to see how is baby handling those contractions. And so usually it means you have to be on the monitor some during that time. If baby's handling it fine and everything's going well, according to policy, after a certain amount of time, we can take you off the monitors, let you walk around and do stuff like that. And that's would be considered early stage of labor. Same with the Cervidil. Cervidil is a little like tampon-like flat plastic piece with similar kind of medication. Has a string attached. We soak it in saline and then place it up inside. And I push everything up inside because I don't want it to be tugged on and it come out. And it can stay in for 12 hours. During that time, again, we would monitor the baby appropriately, and if you start having contractions, monitor to make sure the baby's handling those contractions well. Use therapeutic rest during this time to kind of help with it because it is crampy, it is uncomfortable. Sometimes these meds will kick women into actual labor, and I don't apologize. I say, great, this is exactly what we needed. We needed you to be in labor. Your water's broke now, 12 hours, you're not dilated. We need to sort of move you towards getting delivered so we don't have an infection. Infection can lead to all kinds of problems. So, Cervidil. Once your cervix is a little more dilated, so if we need to do these things. So sometimes you come in, your water's broke, and you're 2 centimeters dilated. I might not use Cervidil, I might not use Cytotec, I might. We can talk about it, preferences, benefits, risks, and you get to make decisions too regarding your care. We have this thing that's called a Cook balloon, and it's hard. I'm not going to open this package up. But here is kind of maybe what it looks like. It's this piece here. This is a blue soft tip, a balloon here, and a balloon here. And the cervix, it goes up inside the vagina, up through the cervix, and the cervix is placed here, and this is up where the baby is. It's not, and it fills up with normal saline, sterile saline, and the bottom in the vagina also. And the two of them squish the cervix together and make it thin. And here's sort of a picture. It can stay in for 12 hours. Usually I reassess every 2 to 3 hours to make sure that it hasn't come out. Because the goal is to have the uterus will start to cramp as a result of this pressure, and the baby head here will push down as the uterus contracts, and this will eventually come out and kind of hang out here in the vagina. Once it's out, I want to get it away because it takes up space, and space I want that baby head coming into. But once they come through the cervix into the vagina, you will have dilated about yay far, 5 to 6 centimeters, and your cervix will be soft and squishy and will be ready then for the hard labor of Pitocin. If you come in already 4 centimeters dilated and for some reason things just aren't progressing, sometimes power is the issue and we use Pitocin to help. Sometimes not. Pitocin, we hang through the IV. We use it low risk. We use very low dose. We start at the lowest possible drip and then keep it there for 30 minutes and observe how does baby and you handle this. If that's all we need, that's all we use. This is a tool. If at some point in your labor things progress on their own and we get that baby's head down on your cervix and things start to move on their own, we can turn Pitocin off. But if after 30 minutes you're only having 1 contraction in 10 minutes, then we bump it up to the next 2 milliunits per minute. And we observe, how does baby handle that and how do you handle that for 30 minutes? And so on and so forth, until we get you into a regular contraction pattern of about 2 to 3 minutes, lasting about a minute long. Sometimes even then we can't tell if it's strong enough, things just aren't progressing. And so one of the ways to be able to tell, we need to know, what can we do to help this labor progress? I don't want an infection and I don't want a C-section. What kinds of things can I do to help labor progress? There's a thing called an intrauterine pressure catheter. I can't see what you're showing, so I want to just see. It is a tube. It's thin and flexible. It's just kind of like IV tubing. It has this handle piece, and on the bottom, This connects into a pressure gauge, just like your blood pressure measurements. This goes up alongside the baby in the uterus, so kind of like this. It doesn't hurt the baby, it just goes up through the cervix alongside the baby, fills up with amniotic fluid, and then flows here to the pressure gauge, and it gives me an exact power. We want about 200, 200 is the power we'd like to be able to say, okay, these contractions are strong enough. I don't need to give her more Pitocin. I don't want to give her more Pitocin. Or do I need to? Are they only, 50 units in a 10-minute period? Okay, we need to sort of increase the power. That's why this isn't progressing. This is a tool I use. Sometimes it's helpful for me to facilitate the delivery so that, again, we avoid some other issues. I don't want to wait 12 hours to put something like this in if I'm not sure you're strong enough, because then I've wasted 12 hours of time giving you 12 hours of increased infection risk. Nobody likes this. Nobody likes this one. So sometimes baby doesn't tolerate labor very well, or I'm just not able to monitor well. These are flat things on a round belly. They slide. When you move, they slide. We can't pick baby up. It can be quite a problem. If I have something going on that's making me worried that the baby is not doing well, and I really need to know what that baby is doing to decide, can we proceed or do we need to stop with this labor? While I don't like it, I place a fetal scalp electrode. It is a little needle that is in a circle, and it goes right on the baby's scalp. It does not go into the bone or anything, just onto the skin. Most babies heal from this puncture wound very quickly, like in a couple days. You don't even notice it. It then has an electrical lead, and then we can detect the baby's heartbeat right from the baby. So I don't have that missed heartbeat because of the monitor not picking up well for some reason or something. Again, if I have a baby whose heart rate's dipping down into the 60s and I can't monitor well and I need to know exactly what's going on, this is a handy tool. Sometimes I can say, oh good, baby's okay, we can keep proceeding with this vaginal labor. Sometimes I say, oh my goodness, no, this is telling me it is not safe to continue. Our goal is to be safe and not push things so that we have emergencies happen and act before there's an emergency. Sometimes in labor, babies don't tolerate contractions, and there can be a lot of reasons why that would be. There can be a cord that's being pinched somewhere, not always just around the neck. Sometimes they're just being pinched somewhere. And if your labor is, there can be other things. The placenta may not be functioning well, or the baby's position is just uncomfortable and the baby's not liking it. If your labor is progressing and the baby's giving us a little bit of trouble, let's have a baby. Let's just get this done and have a baby, right? But if you are 4 centimeters, you're not progressing, it's been hours and hours, and this baby's having deep D cells, and things are just not looking good, we will try things. We will do these interventions to see if we can address those issues. We will turn you to your side. We will give you IV fluids and oxygen. We will, reposition, see what we can do. But if this is just not progressing and the baby's looking worse and worse, we are not going to keep pushing this until it's a disaster. We are going to say to you, we've tried these things. These are the tools that we have. We're worried about your baby. You are going to be part of that conversation. At no point there are very few true emergencies where there cannot be a conversation where you are not aware that there's something wrong. Yes, things do happen. Waters break, cord prolapses do happen. The cord comes down before the baby's head. That is a true emergency. Then we will say to you, we need to go right now for a C-section, because that baby's head will pinch that umbilical cord and it is a life-threatening problem for the baby. There are things like abruptions that happen, and mom's bleeding and the baby's heart is decelling, and we cannot, no amount of turning or fluids will fix that. We need to get a baby out. And again, if you're not ready to have a baby at that point, we need to move towards C-section. Okay. Infection. If you're 10 centimeters and you start to have a fever and your baby's heart is tachycardic and you've had a long labor and this is looking like you might be developing an infection, push and have a baby. Get a baby out, right? If you're 2 centimeters and you have a fever and your baby's heart rate's in the 180s and is giving signs that this is an infection, we're not going to wait 24 hours to have a baby. We need to deliver your baby to avoid more serious complications from happening. And again, we need to talk to you about these things. These need to be a conversation. Shoot, I had a train of thought, now I don't know where it was. I have a lot of people who come in to me and they say, oh Joy, I want to have this natural birth, I don't want an epidural, I don't want, all these things, these interventions, these they don't want. Okay, but if I have to have an emergency C-section, then da-da-da-da-da. Well, we don't have to wait for it to be an emergency. If we do some of these things sometimes that we don't like doing, sometimes we can prevent an emergency from happening, and sometimes we can even prevent a C-section from happening. So while these were not on the plan of the most desired, they're not my most desired as well. These are tools that we use to give you the best outcomes, and that is our goal. We care about you, we care about your baby. We want to keep you and your baby safe. I think this is good enough for now. I think I'll do another video in the future regarding what is the C-section, sort of how that process goes. I'm also going to talk about things like preeclampsia and hypertension in pregnancy, and maybe even some gestational diabetes stuff. But for now, I think this is enough. Thank you.